about health-related quality of life, what that means, how we measure it, and how it might be useful in clinical practice. So first, what is health-related quality of life? Well, it's the quality of life relative to one's health or disease status. Fairly straightforward. It's been identified as a goal for all people across all life stages by leading health organizations. There are many health-related quality of life models applied across different health and illness conditions across the lifespan and among individuals, their families, and communities. Health-related quality of life is commonly conceived as dynamic, subjective, and multidimensional, and the dimensions often include physical, social, psychological, and spiritual factors. However, the specific dimensions are labeled differently by different authors. For example, these broad dimensions subsume more specific dimensions such as emotions, cognitive function, economic status, and intelligence, and they may incorporate friends and family. So first, let's think about what are some different measures we can take that to kind of assess disease-specific symptoms, improvements, outcomes, and then more broadly speaking, generic health measures. So first here we've got clinical markers, right? For instance, these could be like lab reports, or in this case of respiratory function. We've got this test here to measure respiratory output. And so this will give us a value that we can use to kind of determine how well somebody's respiratory function is working. We've got specific symptoms that we can ask the patient. So we can ask them things like, over the last 4 weeks, I've had shortness of breath, and they rate on a scale saying almost every day, several days a week, a few days a month, or not at all. You can look at the impact of disease-specific problems, so respiratory-specific. So not just what are the symptoms you're having, but how is your disease impacting your life? So how much did your lung respiratory problems limit your usual activities or enjoyment of everyday life? So one being not at all, a little, moderately, or extremely. And then we can ask more broadly, not specific to the disease state, but just kind of in general, would you say your health is excellent, very good, good, fair, or poor? And it's in particular these last two kind of measures of the impact of disease-specific problems and overall well-being and functioning that give us a picture of somebody's health-related quality of life. And patients' responses in these two different domains have been extremely accurate in predicting future health, inpatient expenditures, outpatient expenditures, job loss, response to treatment, return to work, work productivity, and mortality. So how do we conceptualize health-related quality of life? And I mentioned there are several different models. So let's start with one of the first models that was developed, the Wilson and Cleary health-related quality of life model. And so this model here combines two paradigms. It combines a biomedical and a social science. Their model is a taxonomy that includes 5 major well-defined domains: biological, symptoms, function, general health perception, and overall health-related quality of life. However, the definitions for 2 other domains, individual and environmental, that were included in their model were never really made explicit. Each domain is related to the others, and reciprocal relationships may exist. The authors also suggested that the environmental and individual factors are associated with outcomes, thus affecting total health-related quality of life. So, following the establishment of this Wilson-Cleary model, group revised their model and kind of simplified it a little bit. So what they did was they kept the same 5 major domains of the original model, but they made some explicit definitions for what individual and environmental characteristics meant, and they simplified the depiction of the model by removing non-medical factors and labels on the arrows portraying the relationships in the figure. In addition, they contributed further theoretical background about the main concepts in the model and provided examples of instruments to enhance measurement. According to Ferrans and colleagues, the model depicts dominant causal associations. However, reciprocal relationships are implied. An explicit assumption is that understanding relationships among these components will lead to the design of optimally effective clinical interventions. And the other kind of nice thing about this model is that it could be applied to any healthcare discipline. So it's not disease specific. So this model is really trying to, if you can identify each of these different things, it might give you an idea of where interventions might be most useful. So it's very hypothesis generating. In this last model I want to show you, this is the World Health Organization International Classification of Functioning, Disability, and Health. It's a model that is designed to provide a description of health and health states while providing a unified and standard language that can be used across disciplines and cultures. The WHO ICF has evolved over time from a focus on consequences of disease in 1980 to components of health in 2001. The more recently developed WHO ICF CY covers infants, children, and adolescents. The WHO has conceptualized health-related quality of life as an individual's perception of his or her health and health-related domains of well-being. Health and health-related domains have been further conceptualized in terms of functioning within the WHO ICF model. The WHO ICF model includes components within two main parts. Part 1 focuses on functioning and disability, so body function and structures, activities, and participation, whereas Part 2 addresses contextual factors, environmental and personal. The main concepts are well defined overall with explicit propositions and assumptions. However, unlike the models by Wilson and Cleary and the revised model by Ferrans and colleagues, the WHO ICF is not specific to health-related quality of life. Some researchers assert that the WHO ICF categories under functioning can serve as the basis for the conceptualization of health-related quality of life, but are not the only potential application of the WHO ICF. For example, one group used the WHO ICF as a framework to organize a comprehensive overview of nursing and interdisciplinary care of the stroke patient. The WHO ICF serves more as a mapping and classification framework rather than as a guide for hypothesis generation in the area of health-related quality of life. One thing that you might notice here across these different models is that they incorporate a lot of the same concepts. So bodily function, physical functions, mental functions, environmental. They consider the disease, and then different personal factors, environmental. And so not one of these models is right or wrong per se. They all have different kind of ideas behind them, and they can be used in different ways. So how do we actually assess health-related quality of life? There are several surveys that are widely used to kind of get an idea of general health. But from these, the concepts that they include are those concepts that are in a lot of these models that we just looked at that can give us an idea of somebody's health-related quality of life. So you can see here across the top of this table, these are the different questionnaires that have been used, and down at the bottom here you can see what these abbreviations stand for. We are going to be focusing on this SF36, the short form 36. And so basically here you can see concepts, and these are the concepts that are important for health-related quality of life. And here you can see this SF36 covers and assesses all of those different concepts. This questionnaire, the functioning and well-being profile, is basically similar to the SF, only it's the long version. So SF36 is the short form of this FWBP, and you can see that FWBP covers a lot more domains. So while it might give you a more comprehensive picture of a patient, it will generally be longer to administer, so it could take more time, and it might not give you that much additional information than the short form does. So, what is so special about this short form? Okay, so this form is a validated, widely used generic measure of health-related quality of life. There are 8 domains that are covered in this questionnaire, and they're scored from 0 to 100. They are adjusted for age and gender. And from these 8 domains, you can get 2 summary scores. You get a summary score for physical component, so measures how decrements in physical function affect day-to-day activities, impact of physical impairment or disability on health-related quality of life. And then the other summary score is for mental components, the impact of mental affect or symptoms of pain on health-related quality of life. The nice thing about this form is that it uses normative-based scoring, which allows this form and responses on this form to be compared with across disease states. Now, there are some groups that have taken this form and they have modified some of the questions to be disease state specific. So, for instance, one example is multiple sclerosis. There's a version of this form that is specific to that kind of specifically is asking about multiple sclerosis. It's not so generic. This here is a figure taken from a paper where the psychometric properties and scales were developed for this questionnaire. And so here what you see under items these are the different questions contained in the questionnaire. There's 36. And these under items here, it describes just a general brief description of what the question is referring to or asking about. And here you can see these questions get grouped into these different scales. So these questions here up top, basically question 3A through J, is regarding physical functioning. Whereas questions 7 and 8 have to do with bodily pain and so forth. So you get these different scales. These are the 8 different scales we have here. And here's the 2 summary measures. So each of these scales contributes to one of these summary measures. This is an example of what the short form 36 looks like. So typically this is a questionnaire that you would give to a patient and they would fill out themselves. Dr. O'Connell has posted this questionnaire on Blackboard and has asked you to complete this form to assess your own health and views about your own health. In class, what we will be doing is administering this health survey to our peers. So we're actually going to do it in an interview format. And this is going to give you an idea of how maybe your views of your health might be different from views of somebody else's health, how they might view themselves, and kind of just to give you an idea of the variability between individuals, and then also give you some experience with interview skills. The scoring for this questionnaire can be a bit complicated, and so there is this nice little scoring program that I have here in Excel, which is posted on the Blackboard site, so you can actually calculate your scores on these 8 different scales. And so here under the response columns, you're going to just type in the numerical value of your response, and then it's going to calculate your scores on these different areas. So definitely not only fill out that form, but also score it and kind of see where you fall on it. And think about, was it surprising to you, or are there any areas that you're kind of like, yeah, I figured that was not so great. It's kind of fun to check out on your own. Feel free to try this out on friends, family, and stuff, and kind of see how their answers affect these measures. So there are lots of different measures, right? And we're going to use the SF-36, but that's not the only questionnaire that you can use. And so how do you choose an appropriate measure for assessing health-related quality of life? So I want you to think back. We're going to do a throwback to last semester, drug lit, and this is where your MAD research skills are going to come into play. Okay? So you're going to think a little bit like a researcher here. You're going to ask some very important questions. So 1, are the domains covered relevant? In what population and setting was it developed and tested, and are these similar to those situations in which it is planned to be used, right? So this has to do with the external validity or generalization of this questionnaire to other populations. Is the measure valid, reliable, responsive, and appropriate? What were the assumptions of the assessors when determining validity? Are there floor and ceiling effects? That is, does the measure fail to identify deterioration in patients who already have poor quality of life or improvement in patients who already have a good quality of life? Will it measure differences between patients or over time, and to what extent? Who completes the measure? Patients, their family, or a professional? What effect will this have? That is, will they complete it? How long does the measure take to complete? Another one is, do staff and patients find it easy to use? Is it easy to complete? Are the questions clear? Is it easy to score and then interpret those scores? And then lastly, who will need to be trained and informed about the measure? The nice thing is a lot of these measures now are offered electronically and can be automatically scored. All right, that concludes this video. Thank you.